you to our Baxter Connected Care webinar for today. I am pleased to welcome Becky Winter from the University of Colorado to share her experience about falls prevention. As we know, falls prevention strategies are not a one-size-fits-all solution, and that many people have become very creative in how they solve this challenge. And that's certainly what we are going to hear today from Becky. This webinar has been sponsored by Baxter as a learning activity, and the presentation has been fully developed by the presenter. All of the lines during the call will be placed on silent mode, and questions can be sent in at any time during the presentation via the Q&A box or by using the chat function. We also want to let everyone know that the webinar will be recorded for educational purposes, and a link to the recording will be available shortly following today's session. And previous recordings can be found on the @Baxter Healthcare US channel on YouTube. I also want to say, as we give people a couple of minutes to log in, if you can share in the chat box where you're joining us from, what your role is in your current position at your organization. I just love this information because I think it gives such a glimpse into the diversity of our audience and those that are joining us. So I'll give everyone a few seconds there. I'm not sure, Becky, if you can see the chat and who's joining.
I can.
Okay, and while we continue that, I just want to take a couple of minutes to introduce Becky Winter. She is presenting today Tech Savvy Safety, Winning the Fight Against Falls with Protocol and Technology Optimization. The objectives are listed on that screen. And like I said, I encourage everyone to put their questions into the Q&A box at the end of, or during the presentation. And at the very end of the presentation, we'll have the opportunity to answer those live. Without further ado, I'm going to pass it over to Becky so that she can introduce herself and start the presentation. Thank you.
Great. Thank you, Michelle. And just a confirmation that you can see my screen.
Yes.
Okay, great. Well, welcome and thank you for joining us today for the webinar. My name is Becky Winter, and I'm a clinical quality and patient safety specialist with UC Health for the Northern Colorado region. And as you can tell by the alphabet soup after my name, I am a nurse and have been for over 32 years. After leaving the bedside, I was a clinical informaticist for about a decade. And then about 12 years ago, I officially transitioned into my safety role with a safety title. Over the years, I've been involved in several IRB research studies related to fall scale development, fall prevention equipment utilization, evaluations, and implementations. I support the falls metric for UC Health Northern Region, and I'm a member of several system committees working on initiatives that are related to falls and other patient safety areas of focus. Disclosures include noting that Baxter Nurse Call, smart beds, and other products and technologies are utilized at UC Health, and I'm receiving an honorarium for hosting this webinar today. So first, I want to share a brief overview of UC Health. It's a network of nationally recognized hospitals, clinics, emergency services affiliates, and providers that extends throughout Colorado, southern Wyoming, and western Nebraska. Our hospitals range in size from critical access to community to an over 900-bed academic medical center that's affiliated with the CU School of Medicine. Several of our hospitals have earned the Magnet designation or Pathways to Excellence, and we have multiple rankings among the best hospitals in the country. And also, we've been recognized as a Level 10 Most Wired Healthcare Organization. We have a deep involvement in implementing IHI improvement, patient safety, and clinical quality initiatives. And my primary focus is within the northern region of our system and is comprised of 2 freestanding EDs, multiple clinics and outpatient services, and 4 hospitals ranging in size from 35 to 275 beds. Among our regional specialties are a Level 1 trauma center, cardiac, stroke, and bariatric centers of excellence, and neonatal ICU. Everyday care teams struggle to do more with less, putting more mental and physical strain on caregivers to keep patients safe. Hospitals deployed traditional safety protocol measures like bed exit alarms to support care teams in ensuring a safe patient environment while reducing falls. However, if we implement this bed exit alarm technology incorrectly, it can end up adding burden to an already busy care team. To accomplish the dual goal of adhering to patient safety protocols while easing the burden on care teams, this webinar will explore the optimal selection of falls prevention protocols and interventions and the technology that can support them. The learning objectives for today's webinar includes understanding the challenges and pitfalls with current falls prevention programs. We'll address the main consideration criteria for selecting an optimal falls program on your care units and facilities. We will hopefully help you understand how the technology you have today and strategic incremental investments in that technology can help facilitate your falls prevention protocols and realize the obstacles to overcome in the implementation process and steps you can take to minimize the risk of change in workflow on your care units. And then lastly, we'll review the successes of UC Health's fall prevention program. So first, we want to preview some of the successes. We have in our facilities that have gone live with bed exit automation technology, year over year, all fall, unassisted fall, and falls with injury rates are 20 to 30% lower than when we compare that to our facilities that haven't gone live. We've successfully mitigated many of the human factors related to bed alarms not being set, and that has resulted in more than 11% fewer unassisted falls due to that particular reason, not having bed alarms set. Automating bed alarms combined with the standardization of domes and tones overhead and via our devices reduces cognitive burden for our staff. Anecdotal feedback from them is that because there are fewer false bed alarms, they have less alarm fatigue. As a system, having standardized domes, tones, and expected staff responses, we've been able to develop internal education and reference documents so that pre and post implementation, we're able to provide consistent education, communication, and sustain those practice expectations. There's amazing vendor support offered for any go live, but once they leave, it's imperative to locally reinforce the education and train new hires. There is a planned 5-year rolling implementation of these technology solutions across our entire system, and we couldn't be more excited. So let's first talk about the challenges and pitfalls with current falls prevention programs. I'll depict the components of a falls prevention program, the whole thing, by creating the following diagram. The first, and often one of the most challenging components, is a fall risk scale or scales based on the patient population, whether it's in your ED, med-surg, or pediatric settings. The second are fall prevention interventions based upon that scale. And the third component is clinician compliance and patient participation. Where these three components intersect is the ideal falls prevention program that we all strive to achieve, where we're correctly identifying those patients at high risk of falling, appropriate fall prevention interventions are in place, and they're implemented consistently by all staff throughout the patient's hospitalization. And then we can't forget the importance of patient participation in their care. Their understanding of their assessed fall risk and their agreement or ability to participate with the safety interventions we have implemented. Taking a closer look at the fall risk scale, regardless of which scale you happen to be using, most were developed with consideration for a specific patient population. In a systematic literature review published in 2021, They noted 38 different fall risk assessment tools. The authors found that many, and the majority were developed for use in geriatric or acute care settings. Some of the most common throughout the literature and in use today include scales or tools that are listed here. And then within the past few years, we've seen the development of scales within the EHR using predictive modeling or AI. The challenge is to select or develop a fall risk scale that performs well. Scale performance is reported as the scale's psychometrics or sensitivity and specificity. And in other words, how well does a scale predict the patients who will fall and who will not fall? If a scale poorly predicts which patients are at high risk and has a low sensitivity, then you'd expect high fall rates. If a scale overpredicts patients at the risk of falling and has a high specificity, then interventions such as bed and chair alarms or remaining within arm's reach while the patient is toileting are implemented inappropriately, and they can result in increased staff burden, increased workload, alarm fatigue, and not to mention decreased patient satisfaction. The ideal scale performance would be to identify a scale with the highest sensitivity possible without overpredicting risk, and a scale with a specificity that's appropriately low without resulting in an increased fall rate. Many organizations continue to struggle to find or develop the ideal risk scale or the ideal score cutoff, if you happen to be using one with a score, where it places your patients at high risk. And over the past 17 years, within our system, we've implemented over 8 iterations of an internally developed scale and multiple iterations of predictive or AI models within the EHR. And we still haven't gotten it perfect. Like other organizations, we've seen our fall rates fluctuate, partially due to scale performance. And at one point, about 2 years ago, across our system, 75% of all admitted med-surg and ICU patients were at high risk for at least one or more assessments. And what we found is that when almost all of your patients are high risk, then none of them are truly high risk. And as I noted previously, it results in staff burden, increased workload, alarm fatigue, and decreased patient satisfaction. Predictive or AI models that leverage data from the EHR are the ideal. They reduce the likelihood that the novice versus the experienced nurse assesses or scores the exact same patient differently. And this is commonly referred to as inter-rater reliability. And I could host an entirely separate webinar just on model development and implementation. So let's shift gears to fall prevention interventions, specifically those for patients identified as high risk. And in addition to what most would consider universal precautions, those are things like the bed in lowest position, non-skid footwear, items within reach, and so on. Additional precautions are added for high-risk patients, and some common interventions include those that are listed. One of the most significant challenges related to implementing additional fall interventions is that of human factors. The implementation of any intervention that's reliant on a staff member remembering to do so poses a risk for omission or failure. Studies on prospective memory show that people can fail to remember to perform a task about 20 to 30% of the time. Factors like multitasking, stress, and lack of cues can increase the failure rate. Length of stay can be a challenge, which according to the CDC is approximately 4.5 days across the US, and on average, 37% of those patients are considered to have polypharmacy issues. And although some medication adjustments can be made during a hospitalization, so those meds that we know can contribute to falls, it often requires ongoing management by their PCP post-discharge because we just can't do it while they're in the hospital. And again, the ideal is to have a proactive review of those meds by a pharmacist if the patient is high fall risk. But more often, we see those pharmacy consults occurring only after a fall, and that's due to limited staff resources. The really great thing is UC Health has a very robust virtual health center, which houses our remote or virtual sitters. And each of our virtual sitters can watch up to 12 patients at a time. And unfortunately, at times, our need for cameras exceeds what we have, or we have cameras and don't have the available resources to watch them. And then the other side of that is we often have to discontinue cameras sooner than desired to ensure that we don't delay discharge based on the patient's disposition. And last but not least, a significant challenge related to the use of alarms or sensors is ensuring that the correct patients have been identified for utilization and that the sensitivity of the alarm is appropriate for the patient. So we'll shift and discuss the third component of a falls prevention program, which is clinician compliance and patient participation. And I already mentioned acts of omission or commission. And a knowledge gap or lack of information can also affect clinician compliance. Unit culture and peer-to-peer accountability or the lack thereof can also affect that. And if the norm on a unit is to allow patients to toilet independently despite the protocol expectations and no falls have resulted, the risk-taking behavior and what we like to refer to as drift can become acceptable. The level of complexity when determining which fall prevention interventions to implement for high-risk patients can affect the consistency in which they are implemented. And over the years, we've had intervention bundles for low, moderate, and high-risk patients. And at one point, we identified confusion or inconsistency among the moderate risk patients. And so we simplified, and we had just 2 risk levels, low and high. And now we're back to having a low, middle, and high. And I'm sure many of your organizations too have gone back and forth. So as I mentioned, right now we have those 3 levels and with an emphasis on falls with injury. And we're doing this using a stratified model, which within the EHR, which identifies for each patient appropriate interventions based on multiple contributing factors. Research has shown that having standardized protocols ensures that all patients receive the same level of care, reducing variability and potential errors. Standardization makes it easier for staff to consistently follow best practices and guidelines. And then conversely, standardized protocols may not account for individual patient differences. So like when I mentioned that we had 75% of our patients as high. Stratification helps prioritize resources for truly high-risk patients, ensuring that those who need the most care or interventions receive it. And what we're experiencing in our region right now is inconsistency and variability in the interventions implemented. And that's due to the complexity of stratification and communication breakdowns between staff. They don't necessarily know what patient A needs versus patient B versus patient C. So if any of you on the call have found the best fall risk scale and implementation of the interventions, I'll be giving you my email. I'd love to connect and learn more. And we absolutely cannot lose sight of the patient and their participation in their plan of care. Depending on their condition and level of cognition, they may overestimate their abilities. They may not understand or comprehend the education or instructions, and many patients may simply refuse to participate or cooperate. And then for staff safety, if the patient becomes verbally or physically aggressive, staff may not be able to implement those interventions without being harmed themselves. I'm going to share with you some of the strategies we used when identifying the criteria for developing our falls prevention protocol. That protocol is standardized across our entire system, and then I'll provide some specific examples. When any organization is evaluating their falls prevention program or protocols, I would encourage them to utilize any of the toolkits published and available from the Agency for Healthcare Research and Quality, the Centers for Disease Control, the Joint Commission, or the Institute for Healthcare Improvement. These toolkits provide your organization with comprehensive guidelines, provide recommendations for standardization, ensures you're meeting regulatory requirements and accreditation standards. They also provide ready-to-use resources, saving time and effort in developing protocols from scratch. They're a great way to compare your current program and protocol against that when doing a gap analysis. And then once you've identified your opportunities for improvement, consider utilizing one of the readiness assessments. And you may have identified what needs optimized, but whether or not your organization is able and ready to do so, both culturally and financially, should be evaluated. Review the literature to identify the most effective and up-to-date strategies for fall prevention to ensure your protocols are based on the latest research and clinical evidence. And this in turn can lead to better patient safety and outcomes. And then create a process map for your fall prevention program. This Lean Six Sigma technique provides your team with more clarity and understanding of the complexity of the process. It helps you identify waste and highlight improvement opportunities. And then taking that process map one step further, consider performing a failure modes and effects analysis. Review the root causes for many previous RCAs and the implemented action items, and then evaluate the reliability hierarchy or RCA squared action strength of those optimizations or interventions you're putting into place, and that's to prevent a similar fall event from happening again. Know and analyze your fall data, and I can't stress this enough, and not just your fall rates, but whether or not the falls were assisted or unassisted, which falls resulted in injury, and what the primary contributing factor for each fall is. Were specific interventions not implemented in your bundle? Data is powerful and can highlight the need for education and accountability, additions or changes to your protocols, additional equipment you may need, or my favorite, the technology optimizations. So I'm going to share with you some very specific examples from our work at UC Health. The first one is pretty simple. When analyzing our fall data, and I would recommend you do this as well, consider analyzing your employee injury reports related to falls, especially those that come in as sprains and strains, and see if they correlate. Why I mention this is because in our data analysis, we do track our fall risk bundle compliance, and we continue to have opportunities with this. One of the most commonly missed bundle elements, even with our assisted falls that we found, was consistent use of a gait belt. And most of you know gait belts don't prevent falls, but what they do is provide a secure grasping surface to aid with the patient transfer and ambulation. And should the patient begin to fall or lose balance, combined with proper body mechanics, it improves your caregiver safety by preventing back injury when the staff member assists the patient down. And so if you have falls with both patient and staff injuries, and that correlates with poor use of gait belts, then you can focus on initiatives to increase utilization. And when we really drilled down to why staff weren't using the gait belts, we found that it was because they were struggling to consistently have or find them in the patient room, or they could see them but couldn't reach them fast enough. Our solutions to address this included contracting the supply of our belts through our linen vendors rather than purchasing them. We increased our PAR levels on each unit to account for our high numbers of admissions and discharges, and we placed a hooker magnet near the patient doorway or bathroom with signage so that when the belt is needed, it's in the designated place. And I laugh at this one because it's really high tech, right? But it's a good example of how powerful data can be and how identifying those true root causes of the failure can drive optimizations. Toolkits, EBP, and research can also drive policy or protocol change depending on the opportunities for improvement you identify. When we identified that we were having an increase in falls in the bathroom, remaining within arm's reach of high-risk patients while toileting was implemented. That did reduce initially the number of bathroom falls, but I suspect you can imagine what it did for both patient and staff satisfaction. Because there was little evidence in the literature, we conducted an IRB research study on the use of toilet or bathroom alarms. We conducted several product trials and implemented a device that could be used with an identified subset of high fall risk patients because it still wasn't all of them. Utilization of an alarmed lap belt when patients are up to the chair or roll belts when patients are in bed has been another intervention we've added to our protocol, and that gives staff just a few extra seconds that they need to respond to those alarms before a high-risk patient attempts to mobilize without assistance. And lastly, I mentioned our virtual health center, and with their support, we've implemented video monitoring to achieve the same. And that's early recognition of patients attempting to mobilize without our assistance. And again, it's only with the analysis of our data that we've been able to identify our opportunities for improvement. And some have been very tech savvy to address the human factors, and others still rely on staff culture and accountability. So this visualization is a snapshot from our Falls Power BI dashboard and is reflective of unassisted fall data for the North region for the past 12 months. We've found that analyzing our fall data and combining that with a common cause analysis of historical RCA findings has been instrumental in identifying our opportunities. So on the far left, the bucket of impulsive, poor judgment patients. These are those fallers in which all of the assigned interventions were in place, and that includes an alarm, but staff weren't able to respond quickly enough to assist or prevent the fall. And why this bucket's so important is these are those patients who have a higher AMPAC or mobility score. They're quick and impulsive. Many of them have altered mental status or are cognitively impaired, and it continues to be our most significant opportunity to date. And a lot of this has to do with staff's ability to respond, right, to a bed or chair exit alert. It depends whether or not they're already with another patient in the bathroom, whether they're in the middle of a floor procedure or a dressing change. If the patient's on isolation and they have to gown up before they can even enter the room, we saw a lot of this during COVID, right? And then we have to take into consideration what the staffing matrices are. We don't like to talk about it, but really how many staff are working and what percentage of the patients in relation to the staff are high risk. So we strive to have staff respond to a better chair alarm within 17 seconds or less. And any longer, and the alarm may just be telling you to pick your patient up off the floor. So then our second most significant opportunity right now is what we call patient condition. These are patients who were assessed or scored as low fall risk or moderate fall risk and didn't require or indicated that they needed standby. They can be up and independent in their room. And these are unfortunately the patients that our falls risk assessment or clinical judgment are missing. And you probably recall when I spoke about a scale's sensitivity and specificity. These are patients who are experiencing things like syncopal episodes while they're up or sudden heart rhythm changes. For any of you who have read a lot of Morse's work, she refers to these as unanticipated physiological events, and they are. Only with more sophisticated predictive analytics or AI will we see our fall risk tools identify these patients without over-predicting. And then I'm going to skip to our fourth opportunity, which I'm sure many of you are also unfortunately experiencing, and that's the bucket related to violent and aggressive patients. At UC Health, our staff are trained on dementia care, basic de-escalation techniques, and we utilize CPI. But when a patient becomes violent or aggressive with staff, we teach them and reinforce that their own safety at that moment trumps the safety of the patients. They're not to remain within arm's reach of a patient if they risk getting hurt. So there's very little we can do to address falls related to this. It does impact our compliance with our bundle because they had to step away. But I felt that this type of fall or situation is worth mentioning because unfortunately, we haven't found a technology solution to address this type of fall. But using the EHR to nurse call interface, facilities can leverage dome lights to at least alert staff that the room they're going into is for a patient who has maybe a high bro set. So let's jump back to our third opportunity, and that's bed alarm. And this is where I want to focus the most. It's a category we've been spending a great deal of time and effort on to address, and falls within this category are related to the bed alarm not being set when indicated. And this category or root cause has also been identified in our common cause analysis of several RCAs. With this category, in partnership with our vendors, we realized that we could impact the number of these types of falls by leveraging technology. And there are studies out there, you can find them either way. They either support or question the effectiveness of better chair alarms as a fall prevention intervention. And I think you'd all agree that the challenge with this is implementing multiple interventions in addition to the use of alarm is when we can reduce falls. And it would be unethical to withhold or not implement interventions, especially those that we know work, to isolate and study just a single one to determine its efficacy. And that's why many studies have been so inconclusive related to the use of alarms. At UC Health, we do use them. They're effective in alerting staff that a high-risk patient is mobilizing without their assistance. And in the absence of an alarm, we wouldn't be aware that a patient who does need assistance or could be seriously injured if they fall has gotten up, because we don't have cameras in 100% of our rooms. What's imperative is that, again, the correct patients for use of the alarm are identified and that the alarm sensitivity setting is also appropriate. Identifying for which patients and alarms are appropriate on depends on which fall scale or assessment tool you're utilizing. It's a real balancing act. And then just to reinforce, we have made the mistake of over-assigning the intervention. When 75% of our patients were high fall risk for at least one assessment, alarm fatigue among our staff became a real thing. And now we've shifted kind of the opposite direction. And unfortunately, in our region, we're seeing an increase in our unassisted falls and falls with injury. So we just haven't found that sweet spot where we really are using the technology well. When using bed alarms, the sensitivity can also contribute to alarm fatigue if you set it too high, or not assist in preventing falls if you set it too low. And I'll give you an example using a fall we just experienced, and I'm sure many of you can recall a similar event. This was a high fall risk patient, had been admitted due to an acute ischemic stroke, had hemiplegia, was intermittently impulsive. For most of the shift, had appeared to be using the call light appropriately. The nurse ensured that the bed alarm was on, but selected the low sensitivity. And whether that was intentionally or accidentally, we really don't know. And all of the staff were in other rooms when they heard some commotion, followed by the thud, and then the sounding of the bed alarm. And the bed alarm worked as intended. But what staff needed to know is if the patient was trying to mobilize without calling for assistance so they could get in and intervene quickly. And the opposite can be true as well. So if in your protocol it states that all high fall risk patients must have the bed alarm set on the highest sensitivity, then your staff will likely suffer from alarm fatigue because their patients are merely weight shifting in the bed or turning and the alarm is going off. So that's way too high. It comes down to not only selecting the correct patients, but teaching staff to assess and consider which sensitivity is most appropriate. And luckily, the beds do default to the middle setting, which from my experience and from most staff, it's the most appropriate for your patients. We had identified which patients were appropriate for bed alarms, as well as which sensitivity settings were recommended, but our further analysis still showed us that greater than 15% of our unassisted falls could be attributed to not having the bed alarm set for those patients. And from our case reviews and RCAs, we identified the causes were due to simply forgetting to set the alarm, forgetting to plug the bed into the wall, or not having the magnetic bed connecting cord seated correctly, so the bed couldn't alarm through the overhead nurse call system. And then the other reason was not realizing that the patient was high risk or disregarding the assessed risk that the EHR presented and choosing not to set the alarm. And these are all human factors, and this is, again, where technology came into play. Utilization of staff locating badges was something we already had in place and had been using for several years, but primarily they were just on our nursing staff. So nurses, CNAs, PCTs. We already had the admission, discharge, and transfer, or ADT interface, coming from our EHR into the nurse call system. And it's great. What it does is automate the assignment of the patient into the room and the call system. And then I want to stress the importance of your partnership with your vendors. They can help you understand the capabilities of the technology you have, and it really is critical. Maybe your facility has smart beds, but doesn't have staff locating abilities yet. Partnering with your vendor can help you realize what components of the technology you can leverage now. And then if you can, share that falls data and RCA findings with your vendor, because based on that, they can often make recommendations for technology that can address those identified root causes. We chose to address these issues to implement the bed exit automation technology, and that leverages our staff locating badges and the nurse call system. Many of you may be familiar with this technology and how it works, so I'm going to give you an extremely simplified explanation. So patients with falls risk turned on within the nurse call system, whether it's from the status board or the wall console, it automates the canceling and suppressing of the bed alarm based on the caregiver presence in the room. And so once they leave the room, it automates the rearming or resetting of the bed exit alarm when the caregiver leaves the patient room. It addresses that human factor associated with remembering to physically set it. So at implementation, and this was several years ago, we chose to default having all admitted patients as at risk for falls until the nurse could assess them. And then after assessment, if they were found not to be high, then the risk was removed. And I'm aware of several other hospital systems that have chosen to default all patients to falls risk erring on the side of patient safety in that first 12 to 24 hours of admission. So we started with that. And then within the past 9 months or so, we've switched back to having the system default to fall risk off. And what we're seeing in our region is that staff are often not able to complete that fall assessment as timely as we would like, especially when the admissions happen at or near shift change. And then our EHR assessment takes up to 12 hours for the data model and automation to work. And so in our region, we're beginning to see more falls within that initial 12 to 24 hours. And our staff are actually asking to have it default to high risk again. So I would recommend, if anybody chooses to do this, err on the side of having it on. With the guidance of our vendors, we chose to assign staff locating badges beyond nursing, and that was to any staff that mobilized patients, including physical and occupational therapy and transport. And we even ended up badging one of our rehab unit providers. We couldn't break him of the habit of going into the patient room and sitting on the bed. So we badged him. Each organization can determine which of their staff wear the badges, and at our smaller facilities, they have actually chosen to badge any patient-facing staff. So leveraging our staff locating badges and implementing patient safety helped us address the human factor related to forgetting to set the alarm. But what it couldn't do is address the human factor related to ensuring that the bed was plugged in and connected to the system. And this can happen when staff plug just the power cord in because the bed will work, and then they forget to plug the bed connect cord into the wall outlet. Or they do plug it in, but there's actually a damaged pin within the cord, so it truly isn't connected. Our staff were damaging so many of the pinned connecting cords by either rolling over them on accident or yanking them out of the wall that we transitioned to magnetic breakaway cables. And unfortunately, they aren't ideal either. They're better, but because they're magnetic, they can stick together and they appear to be connected when they aren't fully seated. So technology that's available, and we have trialed it, is the Ready Connect device, and it's Bluetooth enabled, and it eliminates the need for the connecting cords at all. You still have to have the power cord, but as soon as the bed is near the head wall, the connection between the bed and the wall outlet is made, and then that outlet is still available to plug in the power cord. It's very cool. We also ensured that our units had the nurse call status board, which is a visual display of the beds on a unit. It was either on a second monitor at each nurse's station or displayed on a large screen next to our bed boards that are posted on the wall. And one of our best practices is for the charge RN or designee to perform an audit for the entire unit from the status board at least every 4 hours to ensure that any of the patients noted in the EHR as needing a bed alarm have fall risk turned on, and the bed alarm is armed, at least 3 side rails are raised, the bed is low, and the brake is on, and that's indicated by the 3 check marks to the right. So any staff member at a glance when they walk by this can see if a bed is connected or not, and beds that are connected do, again, show the bed, the patient, and side rail position. If it doesn't, so if any of those items are missing or it's not talking at all, I have highlighted the second row in this screenshot. When staff see that a bed is not connected, we've encouraged them to use the notes to indicate if it's a specialty bed. And specialty beds do integrate with the nurse call. They alarm overhead, but the bed exit automation technology doesn't activate or suppress the alarm on those beds. So any rooms that lack connectivity due to specialty surfaces are verified then at the bedside. Someone has to actually go into the room to ensure that that bed alarm has been set manually if they're high risk. And then if it isn't a specialty surface and they see those 3 dashes, staff know to go into the room, unplug the bed, plug it back in, try to achieve connectivity. So again, I'm going to stress the importance of your partnership with your vendors to understand the capabilities of the technology you have. I talked about the many solutions available to address the lack of bed connectivity, but what I didn't share is an upcoming optimization that we should all benefit from in a future software release. This optimization wouldn't have been possible without us as the end users asking our vendor partners, what else can we do? Because we're still having issues with this. We ask, how can we know without looking at the status board if a bed is offline or disconnected, or it doesn't work with bed exit automation technology? So what we asked was pretty simple. Dome lights that we use, they illuminate, indicating when risks are present, calls are placed, or when there's an emergency. And what we ask is, can a dome light illuminate if a bed isn't connected or it's a bed that doesn't work with our automation? And then once you plug it in and it's working, it shuts off. So that would be a visual cue for staff when they're walking down the hall because they can't see the 3 dashes on the status board. So with our vendor partners and their marketing and development team, we are going to have a visual indicator at the dome light when a bed isn't connecting or communicating. And I just really think that's really awesome. So invest in that partnership. If they don't know the answer to one of your questions, they're more than willing to find out. And don't be afraid to ask about things that may seem out of reach. If it's not in the current functionality, there's no reason you can't ask why not. They're great. And then realize that unless you're a beta site, other facilities have implemented technology before. Learn as much as you can from them, partner with them. Your vendor can connect you with them so that you can all benefit from that shared learning. And the last human factor related to bed alarm falls is that of staff simply not realizing the patient requires an alarm, or they saw within the EHR they were high risk, but for various reasons chose not to turn the alarm on. Maybe they didn't feel a score reflected in the EHR was accurate. Maybe they didn't observe they observed the patient mobilizing well, and then they didn't take into consideration that if the patient fell, they could be seriously injured, because there's a huge difference between your ability to mobilize and your risk of falls. They're intertwined. This exact scenario has occurred more than once, and a lot of times we get lucky, but sometimes we don't. So to decrease the likelihood that fall alarms aren't implemented when indicated, we've been working with a team of our clinical informaticists, IT analysts, and our vendors to develop an EHR to nurse call interface. And how that'll work is it'll refresh every hour on the hour with the score coming from the EHR. And if a staff member has manually shut off the fall risk within the nurse call system or on the bed, and the patient has been assessed or scored as high, the bed alarm will turn back on. So every hour it'll reset itself. And on the right, I've included a screenshot of the process map associated with this functionality. And I know you probably can't read it, the font's much too small, but I wanted to share the example because I mentioned map out your process, identify where it might fail. In the most ideal state, this will address this contributing factor, but there's still the risk that the patient gets up sometime before the system resets within that hour, or the patient's sitting in the chair, not in the bed, but this is a start. And why we're so excited about this optimization is because healthcare staff come to work each day to care for patients, to help them heal and become healthy so that they can discharge home or wherever they came from and get back to their life. None of us come to work with the intent to cause or contribute to patient harm. And if we can leverage our technology to help us as humans keep patients safe, then that's what we're hoping to achieve. So now it's time to share some implementation obstacles and ways to minimize workflow impacts. Standardize sooner than later. When implementing the technology across multiple units or facilities, remember that just because you can customize many features or settings at the individual unit level, from experience, don't. You'll be going back later and fixing it. Keep it simple. Keep it the same, or you'll find that you're needing to standardize later. And an example I'm going to share with you is a project that we call Domes and Tones. So with the nurse call system, there's domes outside of the patient rooms. I mentioned those before. And the lights and colors can mean various things, like whether a patient is a fall risk, has a skin risk, which staff are in the room, different patient calls, you name it. It's endless opportunities. With some calls, you can choose to initiate a tone overhead, which accompanies that call. And the one most hospital staff are familiar with is the code blue, because usually it sounds quite ominous overhead. Several of our facilities share servers. So if one facility wants to make a change, it actually affects another facility. And so through the Domes and Tones project, it was discovered that there was 61% variability in what we were using across our system. And this makes it very difficult for any staff who float between facilities and even between units at a single facility. And after 2 years, took us a while, but working with cross-departmental and system committees, we're moving forward with less than 5% variability as a system. And we've formed a steering team, which includes cross-departmental representatives, frontline leaders, and our vendor partners, and we meet every other week. And now Domes and Tones is under the umbrella of an even larger project called Unified Comms. So the Unified Project Comms vision is to build a communication platform, and it connects to the patient's electronic health record that easily identifies the right recipient for communication, minimizes disruption for all parties, and minimizes errors and miscommunication. The values guiding the project include a single source of truth, which is through our EHR, and simplicity and ease of use. And then multi-purpose devices. This picture might look familiar to some of you. This is one of our charge nurses. And single devices, once you have unified comms, can replace the multiple devices our staff have now while ensuring those targeted, actionable alerts and communications. So you might be wondering, why are Domes and Tones? And, I've been talking falls, and why are they under the larger umbrella of unified comms? It's because by partnering with our vendors, the alerts and tones that sound overhead from our nurse call system now can ring through the devices as well as overhead, and those sounds are the same. And that further reduces the cognitive burden for our staff. And here on the right is just a snapshot of one of our educational documents for Domes and Tones, which reflects our system standards. So let's revisit some of the successes that UC Health has observed with the implementation of our falls prevention program. In our facilities who've already gone live with bed exit automation technology, year over year, all fall, unassisted falls, and falls with injury rates are 20 to 30% lower than our facilities that haven't gone live yet. We've successfully mitigated many of the human factors related to bed alarms not being set, and that has resulted in more than 11% fewer unassisted falls due to the lack of bed alarms. Automating bed alarms combined with a standardization of those Domes and Tones overhead and via devices reduces cognitive burden for our staff. And the anecdotal feedback from them is that because there are fewer false bed exit alarms, they have less alarm fatigue. And then as a system, having those standardized Domes, Tones, and expected staff responses, we've been able to develop internal education and reference documents so that pre and post implementation, we're able to provide that consistent education, communication, and sustain those practice expectations. And then over the next 5 years, there's a planned rolling implementation of all of these technology solutions across the entire system, and we're very excited about that. It takes a village to achieve successful implementation of any program. And I want to just take a moment to acknowledge our amazing initial core team who together have made our projects successful, facilitated workflow efficiencies, embraced change, and improved patient safety for our patients.